I actually have three questions for Dr. Watson. If we'll just go through it real quickly so we can get the other questions. One is, do you change your Botox injection pattern for apraxia of eyelid opening? Two is, if you use a topical lidocaine gel, how long does it have to be on before it actually works? Some people come in and say, oh, my other doctor puts it on and then just injects. And third is it okay if you're not sure about zinc levels because they don't correlate with what's happening physiologically, just to take a multivitamin with zinc and call it a day?
So in regards to the first question, for apraxia of eyelid opening, it really depends on if there's accompanying spasm. But I actually do tend to start out with my standard treatment pattern because we don't fully understand why botulinum toxin works for that condition. So I'll start with the standard treatment pattern and then modify based on the patient's journaling. And then the second question was in regards to
topical
lidocaine. In order for that to work, it really has to be on for anywhere from like 15 to 30 minutes, depending on the patient. In general, I actually really do not use it for my blepharospasm patients because I do feel that it could potentially impede efficacy. I do know some patients or some doctors do, and they get great results for their patients, but it does have to be on there for, at least kind of 20 minutes to be effective. And in regards to zinc, I mean, certainly taking a multivitamin and zinc in it is probably more than enough. I think it's something to investigate if you found that your botulinum toxin is no longer working. We have some promising research that suggests there's something else playing a role, and it may be worth investigating with your doctor, especially if they think that there could be absorption issues that's limiting the efficacy of the multivitamin. So I think for the vast majority of people, that's probably more than enough.
Yeah, and I want to stress the topical lidocaine. I don't use it with a lot of patients, but in those patients in whom I do, I actually prescribe it and tell them to use it either as soon as they get to the office or even at home, because it does take a while to absorb. So if somebody's putting the gel on and then just injecting after that, you're really getting no anesthetic effect. It takes a while to absorb through the skin, and that's important. You've got to give it time. So first question, please talk more about Bromanidine.
So Bromanidine is a drop that we use actually for glaucoma, and it basically works through adrenergic receptors in a second muscle that's located in the eyelid called the Mueller's muscle that's stimulated through a different pathway to cause that muscle to flex, to raise the eyelid up a little bit. So it sort of works through another mechanism to target a different muscle than the one which we think is weakened from the botulinum toxin, and it's safe and effective.
Yeah, and it doesn't work in everyone, but it's covered by insurance because it's a glaucoma medication. Upneek is very expensive, and to date, and maybe the other panelists can comment, to date, I have not had a single patient where insurance covered the Upneek. They have to pay in cash, and it's hard to find.
Yes, it's expensive and very hard to get. And the times that I've used it, I've been dependent on samples, which of course is not a permanent solution. But it can be, I think, like $200 or $300 a month. So I hope as we bring attention to it, that the drug companies will be responsive to, its functional needs on the market too. So we'll see where things go with that.
Any advice if I would have to send my glasses out for crutches? We just happened to talk about that. You want to take it?
Go ahead.
So first of all, what are Ptosis crutches? It's basically a pretty simple device. It's like a wire that's kind of soldered on to the back of your glasses, and it's mainly for apraxia or for other paralytic ptoses. So when you put the glasses on, that little wire pushes up against your skin and pushes the lid back to raise the lid. Okay? Aren't too many places that make it. The only place I know in Philadelphia is actually at the Will's Eye Optical Shop, and you can't send it out. It has to be custom made for you, so they kind of have to play with it. Even after you get it back from the optician, they have to mess with it and play with it. The other thing is it's a static situation. Like all of these paralytic droopy lid repairs are essentially static. What do I mean by that? The lid's very dynamic. It goes up and down. It's like a windshield wiper. With any of these crutches, it raises the lid, but the lid stays there, which means it's hard for you to blink. So when you have a Ptosis crutch on, the eye dries out, and you have to take it off every 20 minutes, every half an hour, put drops in, and so forth. So I use it. I don't have too many patients on it, but it's certainly no panacea, and it's very, very hard to get a place to make it. The best place, if you're not in Philadelphia, is to find whatever university ophthalmology department there is that has an optical shop, and they may be able to help you. I know the Will's optical shop sometimes makes it, sometimes don't. Sometimes they do a good job, sometimes not so good. But it can be a frustrating situation. So other than for insurance reasons, is there a reason to use Dysport other than other injection compounds?
Yeah, I think really just the times that I've ventured into using Dysport for patients is really when Botox and Xeomin have stopped working. We were just talking in the break. I have one patient that responds very well to it. I think anecdotally, I do feel that it disperses more, and that has some benefits when we're using it cosmetically. But I do worry about in treating the eyelid area that it could theoretically increase risk of dispersion into unintended areas. I haven't seen that happen in my couple of patients that use it, but I think really just other than trying to find something that works well for a patient, that's the only reason.
And I also want to stress, because when we talk about these equivalencies, we're not knocking Dysport at all. It's a very, very effective, very good drug. And if you're on Dysport, stay on Dysport. Okay, don't say, oh, I should switch to something else. It's as effective as the other two approved preparations. It's just when you're trying to switch, it's a little bit trickier. That's all. What oral medications are available for MEJ?
Like they're anticholinergic medications and dopamine blockers, which are usually used more by neurology for like movement disorders and things of that nature. So probably would defer that to them.
Yeah, I don't think anybody on the panel actually would prescribe them because there are a lot of side effects. And so you really need someone who's adept at prescribing these medications, and that's usually a neurologist. So please clarify, distinguish what you mean by volume versus what you mean by dose, and then generally who reconstitutes, mixes the toxin. So volume is amount of stuff that's already mixed that you're injecting. So it's 1/10 of a cc, 0.2 cc's, 1 cc. Dose is how much stuff there is in that volume. So what we try to do is maximize the amount of toxin in the minimal amount of volume, okay? Because I can mix it and put 5 units of Botox in 0.1 cc, or I can put 5 units into 0.5 cc's. But as we talked about, the more volume injected, the more it disperses, the more it diffuses, and that's good and bad. So the quick rule is put as much as you can of the toxin in as little volume as you can, okay? And that sort of keeps it it doesn't go deep as much, it doesn't disperse as much, and hopefully it will be effective. Yeah. So there's a whole lot here. For the longer lasting Botox, how long until it is approved or disapproved? Or, well, approved or not approved. Let's say it's not disapproved. It's not approved.
We really don't know. It's still in its early studies. So it's been tested in humans, which is great, and we know that it's safe and we know that it's effective. But we'll be at the mercy to see what the FDA does. I think we have no idea.
Okay, so next one we've sort of answered. For the medications for MEJ, do you recommend it daily or as needed? Again, highly dependent on your neurologist. There are a variety of medications, and even per medication, it's titrated per patient. Some patients can handle side effects, some patients cannot. So it's really, really variable. A lot of these medications, I will say, what little I know about them is they're not necessarily an as-needed kind of medication. Some of these medications need time to kind of build up in your system to reach a kind of a stable dose. So a lot of, not just with this, but with antibiotics and with the other things we use, we don't like to use them kind of as needed. Typically, you titrate the dose and stay on that dose. I hear that you shouldn't rub your eyes for a day, and others say just for an hour after Botox injection. Doesn't matter to me. Yeah.
Me neither. No restrictions.
Yeah, I think it's like the whole shaking thing. You can follow a ritual, but you have to make sure that ritual is tested. And just like with the shaking, where we were all kind of walking on eggshells around this sacred Botox vial while it was reconstituting, makes no difference. Okay, so I don't have any restrictions either. I say, just do whatever you want to afterwards. Regarding pre-tarsal injection, do you always limit injections to medial and lateral? And do you always feel that the injection in the middle of the pre-tarsal area increases the risk of ptosis?
I do always inject medial and lateral, and I do feel that a central injection could increase risk. If you're lower down at the margin, theoretically, maybe less so, but I do think injecting medially and laterally decreases the risk of ptosis.
Yeah, I never, ever inject centrally in the upper lid. And I don't know if Dr. Murkison wants to comment. It's just that it's medial and lateral. I don't like doing it in the center of the lid. And ptosis, even with a medial and lateral injection, you can get it. So do Botox injections after a while become ineffective immunity? You know, from, I guess.
Yeah. I mean, I think, you know, as we talked about the antibodies, I think there used to be more in the early 90s concerns about the body making antibodies to decrease the efficacy of the botulinum toxins. But studies have shown, and especially in blepharospasm, that really the antibodies do not play as much of a role. So, you know, I just don't think we worry about it quite as much now.
Can Botox or clonazepam cause a runny nose?
I don't think so. I haven't had a patient.
I don't know about the clonazepam. But that's just like, yeah, it's benzo, so it shouldn't cause any problems at all. It's not, it doesn't have any cholinergic side effects. And Botox, I've not heard that. Sometimes we'll inject people here that have the kind of twitchy nose with mesh, but even with those patients, I've never heard anyone say, "Oh, I've got a runny nose afterwards." Yeah.